Nursing care of the patients with central nervous system disorders. Okay, you can find chapter 48 starting on page 1000 in your textbook. We see our learning outcomes here. Make sure that you review these. You're responsible for everything and all of these content of these chapters, right? This covers neuro. So it's 4 chapters. Meningitis is what we're starting with. In this chapter, this is infection that causes inflammation of the meninges surrounding the brain and spinal cord. So we will see purulent exudate, increased intracranial pressure, yes, ICP, possible cranial nerve involvement. This can be manifested from bacterial or viral, okay? So those are the different bacterials that they can come from. Signs and symptoms, usually a sudden onset of headache, fever, phototopia, petechial rash, nuchal rigidity, positive curing and Brudzinski sign, nausea and vomiting, encephalopathy. So make sure that you are well aware. This is a big one, and that's something that you can see. Here are illustrations that are as well on page 1002, figure 48.1 of the Kernig's and Brudzinski's sign. So they'll have pain when when you try to lift their leg like this, which is not normal. And then as well here, pain, they have them straighten and then bend their legs, and they have pain when when you're trying to lift, so their head is down, and then when they go up position, they have severe pain. Okay, we can see seizures coming from complications of meningitis, permanent cranial nerve damage, and possible permanent neurological deficits. Lumbar puncture is how this is diagnosed, which we saw in the previous chapter, in chapter 47. Chapter 47. There was an illustration of someone getting a lumbar puncture where they take that synovial fluid and test it. Culture and sensitivity, they'll do CTs and MRIs. We are going to give them antibiotics, antipyretics, cooling blankets as needed, dark, quiet environment, peacefulness, analgesics with codeine products, corticosteroids, antiemetics, and droplet isolation. If it is a bacterial infection, they have to be in isolation. Okay, so you can see these are some of the, so for increased ICP, they will have possibly a CSF drain that needs to be put in, and you can see that it's a catheter on figure 8.48.3, so that it will relieve some of that CSF pressure and get their fluid content down. Patho-inflammation of brain tissue, so it's just really swollen, right? And the brain cavity is within the skull, and if your brain is swelling beyond that, for obvious reasons, everything's going to be intensified. Nerve damage, edema, necrosis, increased ICP. If it is the virus, okay, so now we're talking about encephalitis. This is a virus origin. And you can see, don't forget to look at the nursing care plan for brain infection or injury. A lot of good information, so just review that. What is your role? How do you evaluate? The West Nile virus, mono or herpes virus can be a cause of encephalitis. Signs and symptoms, we see headache, fever, nausea and vomiting, nuchal rigidity, confusion, decreased level of consciousness, all of these things here, okay? Complications, okay, you see here, this obviously, it's neuro, so it's going to affect their eyesight, their motor function. Seizures are a big side effect that we see. CT scans, MRIs, EEGs. These are, and always, lumbar puncture they're going to do. This is how we can treat it. The doctor will prescribe analgesics, anticonvulsants, pyretics, corticosteroids, sedatives. You're going to help with neuro assessments. They need to be closely monitored, these patients. They have an increase in their brain, the swelling, so the blood flow and the CSF. It can be from increased intracranial pressure, can be from a brain trauma such as a car or boating accident, a beating, brain tumor, intracranial hemorrhage. These are the things probably that you might have seen, like in the case of Gabriel Fernandez, who was beaten up. So being so small and having someone very much larger, or maybe a man towards a large man towards a woman, this is going to be how you can suffer trauma from that, and you'll see brain swelling. It could be from a brain tumor. Signs and symptoms: restlessness, irritability, decrease in LOC, hyperventilation. You'll see changes in their pupil size, and a Cushing's triad. Okay. Monitoring. So external ventricular drain. I talked to you guys about that. That is the diagram there. And that is as seen on page 1004 in figure 48.3. And so you can see how that can relieve some of the pressure. Okay, this is the nursing diagnosis that we have to choose from. Okay, headaches. So this is on page 1009. Different kind of headaches that can be afflicted on people. It can be from head or neck trauma. It can be from an infection like meningitis, encephalitis, those types of things. Then your assessment: what's up? Okay, where is the pain? How does the headache feel? Is it sharp, stabbing, or is it a dull, achy pain? Is it throbbing? Aggravated or alleviating factors, like what makes it worse? It could be triggered by smells. I know at least one of you have migraine headaches triggered by smells. So why we don't wear any body spray or perfumes, hairsprays or things like that to, you don't want to be a trigger to a patient having this having any headache. What alleviates it? Maybe a shower, maybe just lying in a cool, a cool, dark, quiet room, something like environment. Different things for different people. Timing: when does it typically occur? How long does it last? So is it after you eat? Is it in the morning or in the evening? Like, look at what their lifestyle is, help them diagnose and find out what triggers are. Ask the patient to rate the severity. So S is for severity here. So 0 to 10, you can give them with description. You ask about the other useful data. So do you, how long have you had them? Like, do you know like what it could be from? Ask them what other useful data. How about your diet? Do you have other problems? Like, a lot of migraine headaches are triggered by dietary issues that they're not aware, that they think I'm not allergic to it because I don't have like anaphylactic shock, but they can be having headaches and GI upset. So ask them about other parts of their body. Is it, if they say every night after I eat this or whatever. Determine the patient's perception of the headache. So what is their perception? Like, do they feel like they're going to die? Is it just something that they've lived with, that they've had for a long time? Those types of things. Patient education. So keeping a diary is highly recommended and useful. Writing down food, stress triggers, all different kinds of things here that we can get from a very accurate diary. Stress reduction, relaxation. Remember, if you're a person that struggles with this, the probably best teaching you can do is to learn it yourself. So do this self, you can self-teach, and then you can regurgitate it a lot better to a patient that is dealing with this if you master it. So if you're someone that has stress-related headaches and you need to teach yourself how to relax, do that. Like you really have to change. You can't just say, I know. You want to get yourself into listening to, try different things, writing. Does it help just to lie down and take a 15-minute rest? Does it help to do some deep breathing? Those types of things. So if you find tools that really work for you, then when you're teaching other people, it's very much more credible, right? Better than just popping pills immediately. Abnormal seizures. Okay, so abnormal electrical discharges in the brain. This is why we want to learn about the neuron in the anatomy. What happens during a seizure, classifications. There's partial and generalized types of seizures. Okay. Again, refer back to chapter 47, A&P. Okay, no cause identified, underlying neurological disorder or a brain injury. This can be from shaken baby syndrome, and the child can always have lifelong seizures. It can be from a number of things, a neurological trauma that happened as an adult, and then they have seizures from there on, just different. They don't really know how. Signs and symptoms, so they have a visual distortion sometimes, odor or sound that can be the sign and symptom of that. And so like a sound, we can trigger your seizure. These are partial seizures. And you can see here, if they last like less than a minute, if it changes, usually if it's more than 5 minutes, it goes into a different category of seizure. Signs and symptoms, because they can fall into a coma. Complex partial loss of consciousness, 2 to 15 minutes, yes. Generalized seizures, absence or staring. This is petit mal. So sometimes people are having seizures and they just look like they're staring off into, so you always want to be very good. Have your assessment helmet on and be watching if they seem like they are just staring. They have periods that they're talking, or maybe they were listening to you and then all of a sudden there's a blank stare. They might be having a generalized seizure. Tonic-clonic, they may have aura, usually lose consciousness, rigidity followed by muscle contraction and relaxation. There is incontinence and a postictal period, so they continue with the seizing. It kind of comes in waves. It's very exhausting to them. Seizures that tests we can do for them, EEGs, and look at underlying causes. We can correct the cause if you find out what it is that's causing it, or as anticonvulsant medication in conjunction with correcting the cause, or maybe just taken for that. Surgical resection, they can maybe make a correction in their brain. Oftentimes for seizures, diastat, which is a rectal administration of Valium that is given, and that will stop a seizure sometimes. It's like usually a fast way of treating that can be done. It's kind of like using an EpiPen almost, but there's not a needle. It's just a insertion rectally that's given into the mucous membranes. Emergency care, monitor their airflow, turn them to the side, right? Because they can vomit, or they can just aspirate, so you want to protect their head. I think I shared with you guys before that I had several patients with seizure disorders. I had one in particular that she was a young girl, and I was with her for a few years. She had seizures, and she was pretty good size. She was thin, but she was long. And so in the bathtub, while she's wet and slippery, we were driving on the freeway, just at school, in her wheelchair, in a chair, on the floor, at a table, in her walking device that we helped her put. It's like with braces, pretty much any and everywhere while she's eating, and food in her mouth. So you got to use your nursing brain here. And what you want to do is just like use your common sense. If they have food in their mouth, if you can, like tilt them in a way that you can get out whatever they have in there. That's why you always want to tilt them to the side. If they're in water, right, you want to make sure that they don't aspirate. They're going to be slippery. So if you can, depending on your environment, who's there to help you, just protect their head. You want to protect their head and protect them from swallowing or aspirating anything. Anything else that happens as fallout can be cleaned up, can be fixed or whatever, but just make sure that, I've had to pull my patient, get her out of the wheelchair while she's seizing. Grand mal seizures can be very physical. Their arms are flailing, their legs are flailing, they're yelling. Get her out of the chair, onto the floor, pull the pants down, pull the brief down, and get a Valium diastat suppository administration. It's not suppository, it's like a syringe with a rounded tip. Get that in and administer it so that you can, if it lasts longer than 5 minutes, you want to do that immediately. That's what doctor's orders are usually for. It's more than 5 minutes if someone has chronic seizures. So observe and document. Look and be aware. How are their seizures triggered? What can I do to help them? I learned a lot about seizures from this one patient I had in particular that I was talking about. And her mother, caregiver, talked to her, and I really do believe that did help to calm her and get her seizure to help get her out of it. So there's a lot of things that you can do. You just have to, it's very individual. Risk for injury, absolutely. Here, nursing diagnosis options were there. Status epilepticus, so 30 minutes of continuous seizure activity, exhausting for the person. They will be exhausted. You can ensure airway and oxygen, administer diazepam. So that's a diastat, the Valium, the diazepam or lorazepam. It's Ativan or Valium that the doctor will prescribe generally. It's just a fast way to give that rectally. Traumatic brain injury. Okay, we are on to page 1015. Hemorrhage, contusion, lacerations can cause cerebral edema, hyperemia, hydrocephalus, brain herniation, or death. So we'll see this like car accidents or boating accidents. Again, abuse, those types of things. Very traumatic. This can be from MVC, falls. So, okay, it just says that. Mechanisms of the injury, acceleration, deceleration, deceleration, or rotational. What does all that mean? You want to look on your in your book here and review those. These are the types of injury that we can see: concussion, contusion, hematoma. Let's see, this is a long chapter I'm trying to get through. CT, scan, MRIs, and neurophysiological testing that we can do for them. Surgical removal of hematoma might have to be surgically removed if it's causing an increase in ICP. They can have to be put into a induced therapeutic coma to let their brain the swelling go down. These are your complications that can be identified. Brain herniation, this is what happens. Okay, lesion causing pressure is here, and there's the herniation. Okay, so you see the protrusion? That's a protrusion. Just think of a hernia in the abdomen or in the groin. Downward displacement of brainstem through the tentorial notch. So, okay, you see here what it looks like? It's supposed to look like, and here is what the problem is. So this is also on page 1017, 48.6. Nursing diagnosis, ineffective cerebral tissue perfusion. These are your options here. Airway, yes. Okay, additional brain injuries. Risk for acute confusion, acute chronic pain, impaired physical mobility. These are additional nursing diagnosis. Okay, brain tumors, page 1019. there is an illustration, 48.7 metastatic brain tumor. It's probably in the next slide here. This is can be benign or malignant. It can compress or infiltrate the brain tissue and cause ICP. We have seizures, motor sensory deficits, headaches, speech and vision disturbances, personality changes, hormone disturbances. You've heard this before and seen people can have a brain tumor that causes erratic behavior, changes in their personality. So people say like something's going to kind of subtly, if it's getting larger, it will happen more often, like that people around them notice that. This is the film that I wanted to show you, the MRI, and it shows there's the tumor, right? Okay, so MRI, angiograms, these are ways that they can diagnose. Surgical removal, generally, radiation or chemo to shrink it, maybe first. Sometimes they'll do a combination of all three. Then they're going to control the symptoms, obviously. Okay, we can see seizures, headache, all of these types of neuro impairments happen from brain tumors. Your nursing diagnosis options. Intracranial surgery. Okay, so yes, this is brain surgery, pretty severe. Because of a hematoma they need to remove, a tumor, arteriovenous malformation, trauma, and or seizures, right? They're going to try to correct this. It'll be a craniotomy, a craniectomy, or a cranioplasty. Those are the different types. Patient education, anxiety control, and then it's going to be an ICU type of case situation. These are post-operative nursing diagnosis options for you. Herniated discs. Okay, here's a nice illustration on page 1023 and figure 48.9. Nucleus of the pulpus herniates and compresses nerve root. So if you can see that it's coming out, it herniates, right? So it's a protrusion out of this is where it's supposed to be in, but it has protruded anything, again, like think of a hernia, and that's the nerve root. So why do people have pain, excruciating pain? Because it compresses on that nerve there, causing a lot of pain and discomfort, maybe immobility. Cervical, it's a very common thing that happens to people. They get herniated discs. It can be injury or it can be unknown origin. You'll have pain, muscle spasm, numbness, or tingling of the extremity because it's the cutting off the nerve, right? So weakness and atrophy can develop. We can check this with an MRI and a myelogram to find out if it's there, where it's at, how severe. Therapeutic interventions, rest, physical therapy, traction, yes, that can be with severe herniated discs. Muscle relaxants, they need your muscles to relax around because they're reacting. NSAIDs and analgesics, epidural and anesthetic, steroids, surgeries. This is usually a very long process, and people greatly have severe consequences, such as opioid dependencies and different things, because they have to live with taking something to help them get through the day. So people have had multiple surgeries. Often opioid addiction will start with something exactly like this. Having surgery can be from injury from sport. That's a well-known one, like a football player, a boxer, or something like that, anything, skier, and then, you get into that addiction cycle of opioid dependency because it's a pain that they're dealing with, and it takes complete therapy. You can't do your ADLs, or your whole life is changed. Okay. Complications of these surgeries: hemorrhage, nerve root damage, reherniation. It's just severe. I saw a policeman that was shot 12 times, and he was on his 18th surgery. He had been shot in the spine and throughout his body. And so this is like, again, he cannot be a policeman anymore. Like when you're like 30, he was like 30 years old. There's IDTV for you. But chasing someone that just he lost it, killed his wife, and then he shot the policeman. So 12 times, but he survived. So it's like a daily just to get up and just to walk, like being on a cane or in a wheelchair at times. Weather affects them, like cold weather, post-operative nursing diagnosis here, acute pain, right? They have problems sometimes with being incontinent afterwards. Okay, spinal stenosis. This is the spinal canal compresses the spinal cord. Okay, arthritis is often the cause of spinal stenosis. It is damage to the nerve fibers that affects the body, interferes with communication between the brain and the body. It can be from a moving vehicle, accident, fall, a sport injury, or an assault. Spinal cord injuries are, these are what we see, the signs and symptoms, okay? Spinal shock, sympathetic nervous system disruption, so vasodilation, hypotension, bradycardia, hypothermia, urine and feces retention. Spinal cord injury. This is the spine. This is what we're looking at here. Your diagnostic testing that is going to be seen, helping you to see where the doctor is going to find where the issue is at. Emergency management, respiratory, GI, GU, immobilization. Okay, if that does not look like a severe impairment, right? So you want to, that diagram of figure 48.11 on page 1027, they showed you should absolutely make sure that you review and look at. You don't need to memorize these, but it's a good idea to know this diagram of the spinal cord and what's quadriplegia versus paraplegia, right? Why it'll show you quadriplegia where the damage is done up above, and then para is more in the middle if the injury to the spinal cord happens there. So make sure that you review that. We're on page 1030 with a halo brace. This is to immobilize. They need for healing. So a halo brace, rods can be put in place in the spine, corsets, body casts. This skeletal traction here, Crutchfield tongs and Gardner-Wells tongs. So this is traction, a pulley system that is used. And you see how that holds. That's very kind of looks medieval looking, but this is the best way that they have found to keep a balance and to keep pressure from not being, so it's very hard to think of how do we let the brain heal. The spinal area, it has to be something that's not pressing, like they can't have a cast around their head, right? Things like that. So this is something that works very well. Impaired gas exchange, ineffective airway clearance. These are your nursing diagnosis options. So just review those. Dementia. You should all be dementia experts, right? We have seen lots of dementia. We've talked about lots of dementia. I'm going to put up some videos on my YouTube channel. A very good dementia often leads, this is the 4 beginning stages of Alzheimer's disease. So that those go together. So make sure that you see that there are some really great, I'm going to put them up and I will remind you tomorrow to look at those. But they are, dementia will generally move on to Alzheimer's. Okay, and this is intellectual functioning impairment. It stops them from maybe just some mild personality disorders, and then they can change into something more severe, such like it can be Huntington's, Parkinson's, Alzheimer's, vascular dementia. It can be from chronic alcoholism and or medication. Okay, these are people that are at lower risk if they have higher education, higher socioeconomic status. Signs and symptoms, recent memory affected first. So I lost my keys, forget where I parked the car, those types of things. Where am I going? And then remote memory affected later. Forgetting how to make toast or make a meal, or the routine of the morning, how to get to work, how like your route that you would take. They start wandering. So often you will see signs of dementia, people with Alzheimer's wandering. That's why they're generally in lockdown facilities when it becomes severe, because they can go out, they can get hit by cars, they can go out naked or with no shoes on, they burn their feet, they get, or in cold areas, the other effects of weather. Aphasia, problems with behavior. They can act aggressive, act out. They can be violent sometimes, hitting people, being belligerent or yelling, and they become eventually totally dependent. Neuropsychological testing will be done, depression testing, medication review. They do all these tests to find out if there's any types of something they can do, and then there is end of life decision making that has to happen. I think that I did show you I'm Still Alice, I believe it's called. So it was great. I'll put that up as a reminder. I think that I did show it to you guys. Okay, and those are your nursing diagnosis. Delirium, it's a little bit different here. So delirium, we will see it can be from pain, hypoxia, medications, and or illness. Parkinson's disease, this is destruction of substantia nigra, decreased dopamine production, relative excess of acetylcholine, impairments of semi-automatic movement. So somebody that's very well known, Michael J. Fox, who has Parkinson's disease, has been very educational about this, and it's always good to see a visual of what a disease is, so that you can kind of, in your when you're reviewing it, find out exactly what a person with that would appear. So they have tremors, they shake a lot. It's an unknown origin. It can be genetic. Certain drugs or encephalitis can cause it. We see they have rigid muscular appearance, bradykinesia. So that's their shaking that they have. Change in their posture. They get their posture is affected. Pill rolling, tremor with their hands. Difficulty initiating movement. So shuffling and freezing gait. So they tend to shuffle along. This is a animation which definitely shows some of these different signs and symptoms that I just manifestations of Parkinson's. Symptoms of autonomic nervous system dysfunction: diaphoresis, constipation, drooling, seborrhea, frequent urination. We want to, you can find all these on 1043. These are what you're going to do. They're going to give dopamine agonists, MAO inhibitors. These are different types. There are deep brain stimulation. Our nursing diagnosis here: Huntington's disease. Genetic, it's often a degeneration of parts of the brain. Okay, so we see dementia, same thing as with involved. Um, all of these things here. It's very similar to Alzheimer's. Here's somebody that has Huntington's and some of the movements that are made. These are some of the testing that they will do, which is very similar. I'm on page 1048. There's that person is 47 years old in figure 4815. So fairly young, and he's having those types of movements. We give antipsychotics, antidepressants, anticholinergics. Stem cell transplants are still in experimental stages, but they have found a lot of, it's not for everyone, but they have found to have some positive effects. Progressive degenerative disease, neurofibrillary tangles. We don't know, Alzheimer's disease, sorry, we don't know where this is from exactly. They've throwing tons and tons and tons and billions of dollars of research because the numbers for Alzheimer's is rapidly increasing. Maybe genetic, Down syndrome, something in our food, something like with something that everyone is getting because it's increasing. Some chemically related thing is what has been talked about, but they don't know, so they're trying to find out. Signs and symptoms, stage 1, increasing forgetfulness, like dementia, stuff that we talked about here, progressive memory loss, irritability. It just gets more intensified from this dementia stage. They will start hallucinating. They can have seizures. It's more severe. Now we're into stage 3. They're going to be completely dependent because they forget how to toilet. They don't. So they're incontinent. Their emotional control, they'll cry, scream, yell, laugh. Their emotional control is lost. Inability to recognize significant others, so they don't identify them at all. They forget who they are, even their spouses or their children, and it leads to death eventually. Okay, so you want to get histories. This happens to people in all socioeconomical backgrounds. MRI, there are different types of Alzheimer's as well. They have PET scans they'll do. Autopsy is really the only way that they can see in their brain. So that is something that obviously is, found out afterwards. That's why they're studying. After death is the only way to really examine the brain. These are some of the therapeutic interventions, our nursing diagnosis options, and here are review questions. Finally. So do these on your time.